Hi everyone, thank you for joining us for this session. We've got a really good mix of speakers and topics, and I hope that you'll all find them really interesting. So starting off this session, we've got Rakesh Arora, from the cardiothoracic surgeon, and he's going to be talking about nutrition in cardiac surgery. Thanks.
Hi, my name is Rakesh Arora. I'm a cardiac surgeon and intensive care medicine specialist at the University of Manitoba in Winnipeg in Canada. I'm really quite honored to be able to give this talk to you today on an area that I'm increasingly passionate about, that around mobilization and nutrition in a cardiothoracic surgery patient. I have no specific disclosures for this talk other than I have a previous honoraria from Abbott Nutrition. I won't be talking about any off-label use of any products, nor specifically speaking to any one product as part of this talk on nutrition. I'd also like to thank some key people, one, the organizing committee again, for the incredible job of adapting this to a virtual platform and the invitation to speak today. That invitation was facilitated by Daisy Sandman, who's been a colleague and a friend for a few years, who gave me the interaction with this group. So I'm very appreciative for the opportunity, again, to speak to you today. I'd also like to thank these incredible people. Kelly Codispati is our physiotherapist who's done some incredible work around modifying how we do mobilization after cardiac surgery, which I'll speak to a little bit later on, as well as our two team educators, Sandy Warren and Belinda Landry, who are integral members of our interdisciplinary team and essential to the whole implementation plan of any process that we describe here today. In addition, there's some proper nutrition experts that I've also consulted with over the years as I've gained knowledge myself and hope to share with you today. Christian Stope is an anesthesiologist from Germany, as well as Paul Wischmeyer from Duke University in the United States. Both are incredible experts in nutrition, have done impressive and important international randomized trials on this work as well, and I'll be sharing some of their insights today as well. Okay, let me start with perhaps the most important slide to really drive home the overall issues we're going to talk about today. And that's the idea of optimize of the patient in the perioperative space. And this can be both in the preoperative phase as well as the postoperative phase. Collectively, this be called rehabilitation. I'm going to talk about prehabilitation to refer to the preoperative phase and posthabilitation for the post-op. But again, we're talking about this global concept where there are three essential components to this process of a new prehab or post-hab problem or process. One, there has to be an exercise component where it's individualized and tailored to the actual patient based on their capacity at baseline and the targets you're setting together to reach. Two, providing optimal nutrition. And the one take-home point again is protein over total calories is the key message you want to get across in both the preoperative and recovery phases of their cardiac surgery procedure. And also addressing the patient's cognitive and mental health issues as well on the category of worry, where we talk about relieving perioperative anxiety and stress and treating with mood disorders and so forth. That last category I won't talk about today in specific, but know that's an important part of the overall interdisciplinary team approach to these patients, where each member of the team brings their particular expertise to treat the whole patient with a unique perspective that's really integral to this overall process of enhancing recovery. So what I'll do is I'll start this talk framing this with a patient example to set the stage, talk a little bit about both why nutrition and changing the way we think about mobilization is important for the perioperative cardiac surgery patient, and how we've started or how your team can start with these processes where you work. If you're new to this area or looking perhaps to refine the processes you may already do very well at your particular center. What I don't want this to be as a data dump where I just show study after study. There are some good studies out there, and particularly some randomized trials in the area of nutrition and others that are important for us to know about. But it's really the overall concepts I want to impart upon today, and I can certainly dive into much more granular detail during the discussion phase of this particular session. I will guide you towards this particular document, which is this guideline statement from the Enhanced Recovery After Cardiac Surgery Society, put out now about 2 years ago, that go through the intraoperative as well as a preoperative and postoperative phase of cares to address several patient vulnerabilities in a 22-step plan. Again, I'm going to speak to primarily the nutrition and mobilization aspect of these guidelines, but I refer this document for a more comprehensive look at all these areas. Okay, let's start with a case example. We have Mr. LR. He is a 58-year-old gentleman referred to you after being diagnosed with a cardiac murmur by his family physician. Turns out he's got aortic stenosis, and it's a bicuspid aortic valve, so he has some dilation of his ascending aorta as well that requires replacement. Upon workup, you find that he's got some degree of progressive dyspnea with New York Heart Association 2 to 3 type class of symptoms, as well as having issues of obstructive sleep apnea and diabetes. After you discuss the options of therapy with him, you have an operative plan. You plan to take him to the operating room there afterwards. So that's a great description, but I've not shown you the picture yet. And often we make our decisions about a patient's readiness for surgery by the eyeball test. And in some cases, that's sufficient. For example, if you have a patient like this, you may realize that patient's probably pretty fit and has a pretty good attitude around nutrition and exercise and so forth, and will likely do okay during a surgical procedure. Perversely, you may have a patient that looks like this. That's certainly a very different category, probably less well nutricized, if that's a word. We'll make it a word for today. May not be very engaged in healthy living in general, as evidenced by his overall facies, as well as the smoking history clearly is displaying here as well. So in these extremes, it's often pretty easy to use the eyeball test. But in most cases, patients don't look like one of these two extremes, and that outside view may not be sufficient to determine the risks of that patient, particularly again around the areas of nutrition and their physical activity. They may be somewhere between these two categories, as evidenced by this middle gentleman. That may look to be a certain age category, but beyond that, it may be hard to know much more about that patient's particular vulnerabilities. Why is this important? Well, when you think about this vicious cycle of what causes vulnerabilities, and this is really speaking to frailty, which is basically a patient's ability to respond to stress or lack of resilience to respond to stress, such as surgery, they first start with some degree of cardiac disease that leads to some degree of negative energy balance, where they're not doing as much because they're limited by their symptoms. Again, in this case, they have New York Heart Association 2 to 3 and somewhat limited in their activity due to shortness of breath with exertion. This leads to some degree of muscle loss, which is a term called sarcopenia, that leads to less strength and power, decreased overall exercise, including walking speed, and therefore less energy expenditure. We expend less energy, we typically take less in, and you start getting this process of chronic undernutrition. Categorize this as malnutrition, which may look, again, like that middle gentleman, where it's not overtly obvious from the outside. Malnutrition is really the unintentional nutritional intake imbalance between protein, micronutrient deficiencies, or other. It's not just necessarily a decreased intake overall, but it may be that, but also then specific elements that are important for recovery from the catabolic phases of surgery, that being protein, muscle loss, and micronutrients. How common in this? Well, if you look at older adults coming into hospital, and this is initially a report from the Canadian Malnutrition Task Force, which may be very similar to the population in the UK, about 40% of patients defined as older adults above the age of 65 can be deemed to have some degree of malnourishment coming into hospital. Looking specifically at the cardiac surgery patient, about 1 in 5 or 20% of our patients could be deemed as being malnourished coming in through for elective cardiac surgery procedure. Why does this matter? Well, there's a huge stress on the body with cardiopulmonary bypass required for cardiac surgery, where there's this inflammation cascade. This is a nice pictorial diagram here again from Christian Stroop and Arlene Hill from Germany that talk about the various phases of the different components of inflammation that increase during the intraoperative and postoperative phase. If someone has a low level of resilience or ability to bounce back from this inflammation, it can lead to runaway difficulties, ultimately resulting in organ dysfunction and poor outcomes for your patients. Some of the risk factors influencing this can be seen in this nice diagram here. And this is divided into preoperative or pre-admission issues, preoperative, intraoperative, and postoperative. So these external risk factors a patient may bring to the table, such as pre-existing malnutrition, they may have increased age or comorbidities, will be the first phase. Next, what we do to the patient with regards to preoperative fasting during that period of time prior to their operation, or worse, if they have delay of the surgery, which happens to us when we have wait lists, for example, in Canada, they may have multiple days of malnutrition that become additive on top of their chronic issues they had before. With increasing complexity of surgery, they may have longer times on the ventilator, require sedation, leading to decrease or delays in return of normal nutrition postoperatively. On top of that, issues of postoperative nausea and vomiting related to fluids we give and or inflammation also play a role. And you can see how this becomes a vicious cycle of compounding acute malnutrition on top of possibly chronic malnutrition issues. Again, why does this matter? Certain cardiac conditions such as heart failure, anemia, and others certainly contribute to malnutrition on top of what we provide to patients in terms of our perioperative processes that lead to worse outcomes, specifically worse function recovery. We're not able to go back to their own home and may require admission to a skilled nursing facility or long-term care facility, higher rates of infection, higher lengths of hospital and ICU length of stay, and importantly, higher rates of mortality. So as part of the guidelines, we've recommended there should be some perioperative or specifically preoperative correction of nutrition deficiencies. Importantly, at least what we can gather extrapolating from the colorectal surgery patient population, because there's not yet a lot of great data in the cardiac surgery patient, it doesn't have to be a long time. 7 to 10 days is likely enough to provide enough nutrition, again, primarily in the form of protein, to help your patients overcome this potential stress if they're malnourished coming in for surgery. And to take this one step further, this is a challenge put forth to all of us by Paul Wishmeyer that no patient undergoing elective surgery should go to the operating room without appropriate optimization. Okay, and that's well and good, but how do you do that? Well, first you have to go through the process of identification. So there are several different scoring tools out there for identifying malnutrition in your surgical patient. This is one example, or it's the perioperative nutrition screening scoring tool shown for you here that has 3 steps and or the use of a serum biomarker of albumin. So if I just walk you through this just for a moment, step 1 is identifying someone with extreme of BMI. So if obviously someone's very thin and cachectic with a low BMI or extremes of age would be step 1 of identification of someone that may be at risk. If they don't meet that criteria, step 2 would be an actual question to the patient looking for any unplanned weight loss over the preceding 6 months. 10% or higher is deemed to be a significant amount of weight loss over the preceding 6 months. Then step 3 is really the more acute phase. What have you been doing most recently in the last week? Have you had a significant reduction in your diet of 50% over the preceding week for whatever reason? If you're yes to any one of those answers, or if you have a low serum albumin, and again, albumin is not the best biomarker out there, but it's one that's usually readily available, and certainly doing this versus nothing is probably of value, then you're deemed to be someone at risk for preoperative malnutrition, and that it should undergo the appropriate consultation with a nutrition clinic if you have one, with a dietitian or some sort of intervention to optimize them before they come through for cardiac surgery, if there is the opportunity to safely delay their surgery to do so. What should you do with regards to intervention? Well, this is one example, again, from Paul Wishmeyer's group at Duke, where they have the preoperative score. When they identify risk, they have this process of doing a high protein diet, along with some other vitamin supplementation, along with immunonutrition and carbo loading preoperatively that's extended in the postoperative phase, indeed for several weeks upon hospital discharge. I won't go into all the issues about immunonutrition today, but just know there are different solutions out there, and I encourage you to learn more about this, and I'm happy to talk about this more in the discussion to follow. Okay, to summarize this section before I move on to mobilization, remember these 6 points. Preoperative and postoperative nutrition screening is essential. If you got to optimize them, protein is more important than overall calories. We haven't talked about this specifically, but minimizing your preoperative NPO or nothing to eat phase or fasting phase before the operation, and look for ways to restart feeding as early as possible postoperatively when it's safe to do so. Consider oral nutrition, particularly for those patients vulnerable, but perhaps for all patients. And if you have to feed patients postoperatively, think about oral before enteral before parenteral. That's just standard surgical sort of dogma. And again, what we talked about, this has to be multiple players contributing to this patient's nutritional plan, because nutrition management is really a team game and requires multiple people to be part of that. Okay, let me move on now to mobilization. And again, this is another good example where, again, I use the term here, it takes a village, where multiple players have to be part of this process to optimize someone's mobility in the perioperative phase. For the purpose of this talk in terms of time, I will focus on the post-operative phase specifically today. So one of the things that I've learned throughout the course of the years is that there are many things we do in medicine and particularly in surgery that are not necessarily steeped in a great deal of science. So our current mobilization protocol has been around for a number of years, and yours may be the same, where we have this ideal scenario where someone undergoes a routine coronary bypass grafting procedure or an isolated valve procedure. They're either up later that night or certainly by post-operative day one, they're standing up and dangling is a term we use here, and up in a chair with some assistance and starting to do some walking. Day 2, 3, they're certainly up the chair multiple times a day. They're eating normally, hopefully, and ambulating with minimal assistance to the point where they're walking independently on day 4, 5, hopefully a time point when they're going home. Now that's fine in what we may have done 20 years ago, but as patients are getting older and sicker, we're coming in higher degrees of end-stage heart disease and deconditioning as a result of that. They have longer stays in the ICU and have more degree of weakness that ensue there afterwards. They may have pre-existing conditions, for example, an amputation or a previous stroke that limits their mobility at baseline that certainly won't be better after a heart surgery procedure. And lastly, we have rigid restrictions in how they can actually use their arms. I'm going to focus on this last part in particular for the remaining part of this talk, around this dogma about sternum precautions to how we limit people from using their arms initially after surgery. Why do we do that? Well, I've been taught, and maybe some of you have been as well, is that this is to help protect the sternum from dehiscence. And therefore, we tell people no pushing or pulling or lifting, nothing over 5 to 10 pounds initially, and grade that up to 20 pounds over the next several weeks, and really minimizing the overall stress across the sternum. Why do we do that? Well, again, it's not really clear. When someone coughs, you're probably exerting about 60 pounds of pressure across your sternum. So then when you look at what we tell people to do, it doesn't really seem to line up very well. So we looked at this as a group a little while ago, again, led by our physiotherapist, Kelly Cottispati, who really took this to task and really questioned, why do we do this within our own program? And is there any data to suggest that we should let them move much earlier after their heart surgery? So this concept of move in the tube, which is a trademark term, and I've provided the appropriate references down for you there, it really kind of tries to modify the way we think about how we treat patients by using standard biomechanical principles. And so while we have this rigid no use your arm policy, or we have previously, we really try to adapt this, allow people to use their arms within a certain constraint, the so-called move in the tube philosophy here, which I'll go into in more detail. So they can gradually use their arms more and more with the appropriate strain across the sternum, but not too much and not causing discomfort. So we initially did this as a quality improvement initiative within our group. And the goals that we set out here as a team was we really wanted to optimize patient function and independence as early as possible for patients, because that was a patient-driven outcome we were interested in. We wanted to decrease length of stay, which is a provider-centric outcome we were interested in. In order to do that, we had to provide the learning opportunities both for staff who have been doing things a certain way for a long period of time, as well as for patients that may hear mixed signals from different people. So we wanted to have a good learning opportunity for everybody and a consistent message across the entire team, so we're all saying the same thing rather than different things perhaps from different perspectives. Lastly, we wanted to provide a process for maintaining this knowledge and confidence in the team and patients over time with the productions of new materials as part of that. So in order to do this with this team, much like what you've seen for the nutrition aspect where there is now a set protocol, we were starting upstream from there, and we identified key knowledge users and opinion leaders within our program. We developed what knowledge needed to be generated and engaged with experts in this area and biomechanics and others to develop this protocol along with existing literature to put this to action. With this, we went through a series of developing printed materials and education videos, and the staff actually provided this mnemonic that you can see here of the ABCDs for moving safely after cardiac surgery. And this was again generated by our frontline staff. So the A for arms, let them move as freely as they allow. If it hurts, B, bring your arms in closer to your body, or C, carry less weight. And D, don't do it if it's hurting more. And so this way you use the patient's own sort of body and their sensibility to know how much they can do and how much they should progress on a given day. So this is part of the implementation strategy. Again, going through this timeline, we started with the small group sessions, created printed materials, and then a training video, which I'll show for you a snippet of that in just a moment. Then went through an actual QI initiative of the whole plan, do, study, and act philosophy to determine whether this works and if it's safe. This is a video, just again, I'll show just a snippet of what this looks like, where we started initially by providing the overall anatomy in a simple cartoon form for both patients as well as staff to understand what we're talking about, where the risk is within the breastbone and the muscles we're using instead of the breastbone itself. With this, we shamelessly commandeered my research coordinator, David Kent, who's behaving as a patient for us in this video, showing the various stages of stages 1 through 3 of a gradual and progressive extension of their arms out from their chest over time as they get up and just go to the toilet, as you're seeing here. So that was stage 1, where they're still relatively close in a relatively small tube around their body, and gradually making that tube larger and larger with their arms going out further away from their body as both their comfort and allows over time. So here's now stage 3, where his arm's fully extended and it is going in, but prior to going to discharge would be the goal. Again, so they have clear instructions, they know what to do when they go home as well. So we're just in the process of publishing this data, so I can't go through all of it in detail today, but I think it's important to share this particular slide with you all, that 1, that it was safe for the patients. We did not find any increased rates of sternal dehiscence. 2, the patients liked it. But 3, the staff found a great deal of confidence in this as well, that it really improved their understanding of the problems, the way that was rolled out to them, engaged them, and they had high rates of confidence in both the philosophy and providing recommendations to their patients going forward. Okay, let me stop there and we'll wrap things up, and I'll summarize the 2 components in these next 2 slides. First, nutrition after heart surgery and before heart surgery is critically important. 1 in 5 of our patients will be considered malnourished coming through the door. Again, this is defined as an unintentional nutrition imbalance, either protein or micronutrients or others. Just eyeballing a patient will not be enough for many of them, and therefore you need to look for it with some sort of systematic way. I provided one sort of opportunity here for your team to think about, if you're not already doing that, based on the perioperative nutrition screening tool from the Perioperative Quality Improvement Initiative, or POQI, and there's materials on their website that you can look at to download infographics for your team. If you identify someone at risk either through their screening or by using a serum biomarker such as albumin, you have to find ways to optimize them preoperatively, and this may need to be tailored to your patient if they have diabetes or not. And using an intervention clinic or a registered dietitian as part of that process will certainly be very helpful in trying to optimize your patients for nutrition. Pairing nutrition with exercise is great, and that's what we try to recommend for all patients. Again, I've not focused on the prehab component today, more on the post-hab. In trying to implement these strategies, it's a team sport, and you have to engage everyone as part of that process. And it will often need to be iterative. You may have a plan to start and may have to evolve over time, as any good quality improvement initiative may do. There has to be the appropriate education and implementation of not just your patients, but also of your staff. And then you need to audit how you're doing after a year. Or at some time point thereafterwards, to know that it's working, that the appropriate uptake is happening, and that there's no harm coming as a cause of your unintended cause of your intervention. With there, I'd like to stop and thank you once again for the opportunity to speak to you today, and I'm very happy to look forward to the questions to follow. Thanks very much.
Thank you very much for that. Thank you very much for that great presentation. If I could ask the audience to score the presentation in the poll that's just been launched underneath the presentation box. Thank you. And I'd like to introduce Tara Bartley, who is our next speaker. So Tara has nursed for 39 years in surgery medicine, emergency care, specialising in critical care, cardiothoracic and transplantation nursing. She qualified as an advanced practitioner in 2004 and a non-medical prescriber in 2008. Tara currently works as a corporate lead advanced clinical practitioner at the University Hospitals Sussex in Brighton and is the lead A&P cardiac surgery at University Hospital Birmingham. Tara also holds additional roles at the RCN and for the Society of Cardiothoracic Surgery and Cardiac Life Support. She's an ALS instructor and peer reviewer for several journals. Her specialist interests are education and workforce transformation, and we're really lucky to have her today. Thanks.
So, welcome and thank you for the opportunity. I'm going to talk now for the next few minutes on how we set up our advanced roles in the cardiothoracic surgical domain. I think we're probably all aware of advanced practice. It should be delivered by an experienced registered healthcare professional, and they're undertaking or received a master's level award, or for some of our more experienced colleagues that haven't gone down that pathway, they've demonstrated an equivalent that encompasses what we call the 4 pillars. So that's clinical practice, leadership and management, education and research. And the core capabilities also of the specific area of practice that we have in terms of our competency. And it's also, most importantly, a level of practice that's characterized by a high degree of autonomy and complex decision making. So from our point of view, if we want to set up a service, what do we need to do? Well, in order to invest in a project of this nature, you're going to have to scope the current service delivery and skill sets. So you need to identify, is there a need for what we call the extended surgical team? And that's a phrase that's been coined by the Royal College of Surgeons in more recent years that demonstrates sort of multidisciplinary team working for the benefits of the patient and the service. So I would suggest that you have a review of their work and also have a review of the Health Education England work on advanced practice. That's really come to fruition in the last few years. A lot of it covers what we in our specialty had already looked at over the last 10 or 15 years, but it's structured it and it's got it in a great framework. The Royal College of Nursing also has some work on advanced practice and has particularly been concentrating on credentialing, so recognition of that in view of the fact that you cannot be advanced practice registered with the NMC. But the Health Education England are looking at it beyond the nursing aspect and incorporating everything for our allied health professional colleagues, but I'll come back to that. What you probably need to do is review both your elective patient pathway and your urgent pathway and understand how the role development can augment those pathways. So you want to review your other roles and identify how development can not only help the pathway, but also training of colleagues, training of ourselves, and in that sense also help with recruitment and retention. If you're going to put package together that will go through with to be considered and to change a workforce dynamic, you're going to have to demonstrate impact. So from a service delivery and a quality assurance point of view, you're going to have an activity analysis, looking at your caseload and case type, look at any adverse events that perhaps could have been handled differently with this sort of workforce, stability of your service as it is currently or as it will be in the future. Service development, what have you done well? What have you failed to do? What have you not been able to do? And how can advanced practice help along those lines? It's always good to have the patient perspective, so some patient satisfaction and feedback. And then we normally think of our multi-source feedback from the 360 point of view for our appraise and our development, but it's actually quite useful to have that from a service perspective as well. So then performance against national targets and the NCBC and our other centres and the way we collect data are good for comparing that. We need to look at our outcomes and also what our key performance indicators are, so known as KPIs. Is it your length of stay? Is it your return to theatres and such like? And then work with your finance team for what we call a cost benefits analysis and include a benefits realisation plan. Quite wordy sentence, but it's actually about using the correct terminology to make sure that the people who are making decisions about whether there's a financial and business plan agreement to go forward are hearing things in the way they would expect. You're going to need to put business plan together, or should I say you're going to need to help put the business plan together. You're going to have to link with the key stakeholders in the department and then the organisation. Definitely use the trust template, because when people are reading business plans, they do them quite a significant number and they need to have themselves focused in the way they expect. So be mindful of the level of detail required to capture the attention of the different interests of the executive panel, and work with your finance team to ensure that data is correct and powerful. So for example, to quote, the locum pay would not necessarily be something that could consider, because it's not supposed to be recurrent. But if you look at proposed savings that can be from a substantive point of view, with unfilled medical posts that then need locums, or long-time use of locums, maybe over a couple of years, you might be able to use that data in a more convincing manner. So then you need to work with the organisation's project management team, stroke business manager, to guide and support you. And I would argue it's these individuals that should probably write the plan, and you should work with them to supply the information and steer the direction. But they are used to doing these, and they're used to using the terminology, phraseology that captures the attention of the executive panel. How are you going to afford to start this workforce change? So funding opportunities, it's worth just having a little think as to what options you have. Would suggest that you explore the internal options for finance within your department, looking, as I said, vacant posts, existing posts, and thoughts for reconfiguration and locum spend. And then explore internal options within the organisation. So what is the strategic vision, or is there a strategic vision? And if there is, how can you capture that in your work that you're doing? What is there in terms of new ways of working, and is advanced practice embedded in that? Have a look perhaps at medical funding. I think one of the issues that we have here is that these workforces don't come from medical backgrounds, so they're often filled from people from nursing and allied health professional backgrounds, and therefore the budget is difficult to work out from which area it comes. And then see if there's any speciality or hospital charity that might be able to give some funding as well. And then explore external organisations. Certainly the money for training is something that should be sourced outside and will greatly reduce the amount of money that you will be asking for. So strongly suggest that you look at the apprenticeship levy, which will fund sort of 12k a year in terms of supporting the MSc. And then Health Education England will also support MScs for 3 years as well. And they also give some additional money for supervision and training. But that isn't necessarily done on a regular basis. So, and it's very regional as well. So you need to look at your regional faculty and liaise with them as to what opportunities there are. And then perhaps think about some of the national charities we're aware of in terms of the British Heart Foundation, and if there's any to explore there. If you are successful in getting the business plan approved, then you're going to go ahead and look at recruitment. And there's a few things to be mindful of. So the key to success is recruiting the right people from either within the department or externally. And I know that when we talk about recruiting from within, it's unsettling because people feel you're going to denude the sort of department of its senior staff. But actually, I would argue that if you don't provide career opportunities and development for your staff, then they will look elsewhere. And if they're particularly keen on an advanced role, then they will be able to go to another organisation, and you will lose your skill. And then your career pathways will open up from your junior nurses without you having the benefit of having kept your senior team. The selection process should identify skills and the potential to develop skills across all the 4 pillars, and also, very importantly, the interpersonal qualities to work at advanced level. So my next point is in bold, and it's about the tacit skills around the tenacity, robustness, and ability for critical decision making, which are the key to success in the roles for the service. So you want to invest in the roles and not underestimate the importance that you need to reduce the likelihood of attrition once you're sort of further down the line. You don't want to train someone and find you can't hang on to them because you don't give them the right grade, or because they can't make that change between sort of, you know, that critical decision making. So if they're unqualified staff, then the other thing you should think about are, if they're going to go onto an MSc program, it's often a prerequisite for entry that they have studied at level 6 in the past 5 years. If qualified, then attention should be given to the individual's qualities on how they will enhance the existing team. If you've got a small team of people, then the dynamic of personality plays a large part. And also these roles pervade into sort of networking and multidisciplinary team working, both within our department and to other areas throughout the hospital and the community. So you need to have good skill sets. So the leadership qualities to embed a new role and roles is also highly important. And so you can have a retrograde step if you pick the wrong personality to deliver that. And just going back to the study within 5 years, it's quite easy to get a module done at that level if you've got people who are wishing to apply and don't have that. When it comes to actually selecting these people with those other aspects in mind, your shortlist should be against a recognised job description for either a trainee or a qualified practitioner, and we have both of those. Should you wish to have any, just let me know. The selection process needs to identify skills across all 4 pillars and the tacit qualities mentioned. And in order to ascertain whether the individuals have those, I would suggest that you had in your interview selection day an element of group work for all candidates to assess in the way they work within the team, their leadership skills, but also their ability to listen to others and the decision making. So this is not really a clinical opportunity. It's normally just a sort of a light-hearted task that looks to see if it can be solved. Then I would suggest a clinical scenario to assess clinical knowledge, formulation of management plan for patients, leadership of self and others, communication skills, and awareness of the individual's own limitations and the need of when to escalate, and also how they conduct themselves within their professional body. Are they the sort of people who will step outside of that and put themselves and the organisation at risk? So there needs to be a demonstration from that point of view. And then finally, an interview, and you could use the first 2 elements to do a long listing down to a short listing. Follow through with an interview that questions across all 4 pillars of the knowledge, skills, communication, ability to relate transferable skills, and insight into the role and the individual's own learning and development needs. What you don't want to interview is to have somebody who just gives you a list of everything that is important without demonstrating how they've got those skills. If you've got a trainee and they've not practiced at advanced level, they may be able to look at what they've done in the past and think about something that demonstrates they've got transferable skills. So they're the people who are likely to get selected. So for the educational requirements, the trainees are going to undertake a master's level award and also complete core capabilities and then area specific clinical competencies as well. And the qualified ACPs will either, as we say, have experience they can demonstrate or education to master's level, and they'll demonstrate evidence of 4 pillars of practice and also the core capabilities in terms of the generic side and then the area specific. And also they will demonstrate the key characteristics of a higher degree of autonomy and complex decision making, or they may well be on the trajectory to be able to do that. So in terms of the competencies, they're going to be generic, advanced and specialist. So refer to established competencies within the specialty across the patient pathway. And we at the Society have a number of those that we're very willing to share. And it's work that we did that seeded some of the Health Education England and Royal College of Surgeons work, but they're certainly still up to date and very usable. But the competencies need to incorporate all 4 aspects of the pillars of practice, not just the clinical ones. Somebody will think, am I competent at interpreting a chest x-ray? But they may not think they need to demonstrate competency in terms of MDT working or communication. So I would refer you to the curriculums developed by the Royal College of Surgeons and Health Education England. They're incredibly robust frameworks, very informative and very useful for this sort of workforce transformation project. And then also I would caution you not to do too much without establishing the competency framework that will be required for the MSc course, because you don't want to overload your trainees with too many different sources. And you may also wish to develop a sort of a higher framework for your qualified and senior practitioners. So perhaps, you don't want your juniors necessarily expect them to be able to interpret an echo, but you might want your more senior staff to do that. But in every essence, you should have a timeline for competencies so that they don't just drift and they are delivered. In order to make sure they're delivered, you need correct clinical supervision and a team around a clinical supervisor that can help deliver the package. Your trainees will have to have a named education supervisor and a named clinical supervisor, and they will usually expected to have been recognised by the trust and or trained on a supervisor's study day. Often they are asked to submit a CV so you can check the areas of expertise and link them correctly with the trainees. And there may be an opportunity with the university course for them to attend and have additional information and preparation according to what the expectations are. So they're required to cover the 4 pillars, meet regularly, particularly for the trainees monthly. And then your qualified team should have a clinical supervisor at consultant level or a very senior ACP meet quarterly in order to give planned support, ongoing development of practice across the 4 pillars. Certainly the clinical supervisor should be somebody who is part of the annual appraisal process as well, and you may want to keep a register. So your continual professional development is only going to be possible if you have a job plan that allows it. So putting somebody full-time, 37.5 hours a week clinical is not going to allow them to fulfill all the 4 pillars. So the Health Education England recommendation, their framework suggests 20% non-clinical time. And if you're going to go down the apprenticeship levy access, you will need to demonstrate that. They won't give you money without that 20%. So that's 7.5 hours a week. And then when you qualify, that moves to 15 hours a month, which equates to 10% of the time. And in doing that, then people are trainees and qualified ACPs are able to meet all the other pillars, and the role and the non-development of sort of other projects for the department non-clinical development for the departments will benefit all in the longer term. So because you're meeting regularly, the appraisal should be just part and parcel of that, but often the professional line management for individuals may be by someone who hasn't got advanced practice in their title. If you've got somebody who leads, then that's ideal. But the role of the clinical supervisor is crucial in being able to join in this process. So the documentation should reflect the achievements and progress in all 4 pillars over the previous year and document how they will be achieved in the coming year. And also the ACP needs to take a responsibility and demonstrate self-awareness for their own learning and responsibility for making sure that their competencies are completed. What we suggest is that at annual basis that there are 5 sort of direct observational procedures documented, 5 mini clinical examinations, 2 case-based studies, and also a reflection across the 4 pillars, either embedded in those aspects or separate. And then for our surgical care practitioners, a portfolio or a logbook may also be appropriate. So it's good to have an oversight of AHP and advanced practice group, and that involves the executive team essentially, so that you have a strategic vision and you have buy-in from them. And then you also feed into that the people that are the service users of advanced practice to be able to make sure that it's reflective of what your needs are. If you do this correctly, you're going to have a career pathway for each of these people. So on here we've got examples of surgical care practitioner teams and advanced clinical practitioner teams, but there's also the PAs and ACCPs and our other allied health professionals. But essentially you should have a tier of trainee, qualified, then more senior qualified, with a lead overseeing them, and then HE are exploring opportunities to have consultant roles as well. Credentialing is a way of being recognised for the level that you're practicing at. Currently, you can't register with an NMC or other professional bodies. So Health Education and the RCN have opened those opportunities up. There may be a sort of a cost administrative process involved as you demonstrate how you function across all 4 pillars, but certainly HE are linking with academic organisations to see if the credentialing can become part of the graduation process as people pass through their academic side of things. So that concludes the presentation. I'd like to invite the audience for any questions, but I'd also like to invite any comments or any reflections from those of you in the audience who also have been able to, just put myself back up here for you, who've also been able to share their experiences. So thank you very much. So good afternoon, everyone. I'd just like to check that you can all see me. I'll wait for IT to confirm that. I'm a little bit late to the session, not because I wasn't here, but because my IT was playing up. So it happens to all of us. So thank you very much. Now, I'd just like to remind everybody that at the end of each presentation, would you please poll all your thoughts and then click the button so that they are recorded. I'd like to thank Jody for starting the session off and our previous speakers. And I'd also remind you that there's an opportunity for you to post your questions as we move through the session, and we'll come to those at the end. So I would now like to just check that polling has finished. And I'll just wait for our polling company to tell us that that's sorted in my chat. And then what I'm going to do is I'm going to introduce our next speaker, which is actually Jody Stafford. So Jody's kindly helping chair with myself today and taking the lead so far. But by way of introduction to her session, she is a perfusionist at the University Hospital of Wales and has been since 2009. Her talk today will be on clinical debriefing for the cardiothoracic team, but her passion's really around improving education for all members of the team, and her specialist interest is one that's close to my heart, actually: human factors, simulation and debriefing. And I think that the talk particularly fits in really nicely with the overall session today, which is looking at extended teams and multidisciplinary team working. So I'm going to now hand over to Jody for her talk. Thank you.
Hello, I'm Jody Stafford, a perfusionist in Cardiff. I'm a lecturer on the MSc Perfusion Science in Bristol, and I'm also involved with a debriefing project, which is part of what I'm going to discuss today. So the aim is to introduce clinical debriefing, but I'm also going to discuss safety culture and guide us through the talk clinical debriefing framework of how to lead a debrief. Most importantly, I want to generate discussion. What more can we do as cardiothoracic surgery departments, and how can we become better teams? If you're joining me from a thoracic or ward environment, then bear with me, because what I'm talking about is relevant to all teams. We all have a responsibility to educate and promote a culture of patient safety. There's mandatory and safety systems in place as part of bypass and surgery, but there's also things that we can choose to do to improve the safety culture. These are a few of the things that we do in Cardiff. Simulation of scenarios is a really useful learning tool. It's even better when the whole multidisciplinary team are involved, as would be the case during surgery. We should be constantly adapting to try and improve and maintain safety. We have a pre-cardiopulmonary bypass checklist, and recently we've introduced an additional second person check. Initially, we didn't think this was necessary. However, we recognise that it's always safer to have this additional backup check. We've also introduced handover checklists and another for the reinitiation of bypass. Staffing is crucial. It's important to follow the recommendation of adequate and supporting staffing levels. If n is the number of theatres running, then n+1 means that we'll always ensure there's a spare perfusionist. This includes out-of-hours work, as we have 2 perfusionists on call. This can make the quantity of call onerous. However, we believe it's a supportive culture which benefits both the team, but most importantly, the patient. Briefing is becoming quite routine, which is fantastic. All members attend the morning briefing. This connects the team and focuses on the patient from the start of the list. Any concerns or additional equipment needs are brought up here. What about debriefing? Is it something that you are doing in your centre already? Debriefing is relevant to every specialty and all areas. In theory, there should be dynamic, honest, but non-threatening conversations that allow a team discussion, reflective conversation, an opportunity to learn, and shared reflection. Simulation debriefing is different to clinical debriefing in that there's usually specific learning objectives, and the debrief will be led by a facilitator. However, they're both valuable tools which I'm going to discuss. Cardiff isn't an ECMO centre. However, cardiothoracic units may be required to initiate emergency cardiac ECMO infrequently, usually 1 or 2 cases per year. This requires multidisciplinary collaboration, decision-making, and expertise. Simulation provides a safe environment to practice. This study day allowed the whole team to learn and practice ECMO initiation and emergency situations. This scenario involved a young patient who, following cardiac surgery, failed to wean from the bypass machine. It's based on real cases that we've done. The TOE image, the patient parameters, and the team discussions led for the decision to put the patient onto ECMO. This practical scenario allowed the team to practice, but also, in addition to the skills learned, non-technical skills such as decision-making, leadership, and task management. This particular scenario, we didn't use a high-fidelity simulator. We used a CALS open chest mannequin and just tubing and connectors to mimic real-life cannula. We need to plan for these events and talk about them. Simulation is a really useful tool for this. However, we could also just sit down as a group and talk about the cases that we've already done and debrief them. Lots of things were learned during this debrief. However, they could have also have been learned from the real cases that we'd done. We designed this course to ultimately improve patient care, but also to develop our team, to educate, improve confidence, and improve teamwork. Attendees included surgeons, anaesthetists, perfusionists, surgical care practitioners, ODPs, and cardiac ITU nurses. We included lectures, practical circuit workshops, initiation of ECMO and troubleshooting simulation, and also a strong focus on debriefing. We were really fortunate that, as part of the faculty, we had 2 Welsh intensivists who'd undertaken ECMO fellowships. Particularly during the debriefs, they were able to offer knowledge that may not have been known otherwise. We also discussed a positive outcome case study from last year, where we debriefed what went well and also the key learning points as a team. It's recognised that a huge amount of learning occurs during the debrief following simulation. This particular scenario, the debrief included the whole surgical team, but also the cardiac ITU nurses. It was really useful to discuss the case, but also how we could manage the situation better next time. Having a multidisciplinary debrief gives different perspectives and knowledge. As part of this debrief, the ITU nurses raised that whilst we're really busy in theatre putting a patient on ECMO, often we don't think about the consequences and inform them in time. The cardiac ITU nurses need to know in advance so that they can prepare enough space, make sure that it's adequately staffed, and we thought that it might be a good idea to invite the ITU consultant and the lead nurse to theatre for a handover before the patient is transferred. There are multiple examples of international guidance supporting the need to perform debriefing as a component of safe clinical practice. The World Health Organization defined debriefing as an individual or team formally reflecting on their performance after a particular task, a shift, or a critical event. The NHS also encouraged debriefing as regular practice. Clinical debriefing is a conversation about anything that's happened during a case or shift to discuss any aspects of patient care. Everyone's input is valuable and all perspectives matter. In fact, by sharing different perspectives, you may reach different solutions or ways to replicate successes. Debriefing may work better if it follows a structure. Critical incidents may occur for many reasons, such as defective or malfunctioning equipment, communication failure between healthcare professionals, human error, or a failure to anticipate challenging patients or procedures. This particular paper discusses fatal air embolism during cardiopulmonary bypass. They analyse what happened and how they could potentially prevent future occurrences. Unfortunately, instances do happen, and most of them are reported and discussed internally and not published for a wider audience to learn from. This particular incident has been repeated in many centres worldwide, and we need to look at if there's anything we can do to increase our safety practices to do even better. There are many benefits of clinical debriefing. It can allow early identification of system errors and potential untoward events, recognition and encouragement of successful strategies and behaviours, improved communication at a multi-professional level, and whole team evaluation. This article concluded that perioperative briefing and debriefing improved the team climate of surgical teams and the efficiency of their work within the operating theatres. A debrief should be able to be done anywhere at any time, safely, with or without facilitators, in a constructive and non-judgmental way, and always prioritising patient safety. It can be really easy to think of the reasons not to debrief and the barriers in front of us. It's true that we won't always have an appropriate time. Sometimes we might be too busy, the case too emotional, or the team too exhausted. However, it should be a tool that can be used when it is a good time. There's no set time you have to do it, and it isn't a mandatory thing, simply an optional extra safety initiative. The talk framework is a step-by-step guide to help facilitate debriefing. It was designed by anaesthetists in Cardiff who have a background in simulation. They wanted to promote a supportive culture of learning and patient safety in clinical settings. The purpose of the tool is to promote guided reflection within clinical teams as a way to improve and maintain safety, increase efficiency, and contribute to a supportive culture of dialogue and learning, which hopefully in turn supports staff well-being. I'm going to introduce you to the tool, the website with lots of useful resources and training videos that have been created. This project has been funded by the European Union and it's a collaboration between Cardiff Health Board and University, Barcelona Health Board and University, and Stavanger in Norway. This project has been rolled out in many countries and translated into at least 10 languages. This is the Talk Debrief website. Everything on here is free and accessible. I'm going to take you to the talk materials section. From here, you can access cards, flashcards and posters which can be put up around the hospital, and the cards can be put on a lanyard so that they're accessible for all members of the team. There's examples of how to debrief and a user guide on the website too, and I'm just going to show you some videos on how to implement it. In clinical environments, learning opportunities arise every day. Talk is a structure that guides a learning conversation between team members following a case or clinical session. This dialogue is called clinical debriefing. It should be a short, focused discussion lasting no more than 10 minutes. It could take place immediately after a case, at the end of a clinical session, or later at a suitable time. Having a talk conversation may be useful following good outcomes after difficult cases, when team members are exposed to new clinical experiences, after near misses or serious untoward events, or in other situations. Talk gives a structure to the discussion so that it is carried out constructively and focused on a common goal. Any team member familiar with the structure may lead the conversation. Clinical debriefing should ideally take place in quiet and private areas, and intended in a blame-free manner. The conversation should focus on learning and improving patient safety, respectfully, avoiding negative comments and identifying positive actions and behaviours, valuing everybody's input, identifying small objectives and following up outcomes step by step. We use talk to find practical solutions for improvement. These small changes impact positively on both teams and the organisation. Starting to talk. Talk is a clinical debriefing framework which follows 4 steps. Target. The first step is choosing the focus of the discussion, being as specific as possible.
So, what should we discuss to improve patient care?
Team members share their perspective and agree on what is important to discuss.
That sounds good. Let's talk about that.
Analysis. Team members review the agreed target, in particular, how to repeat successful outcomes or identify areas for improvement.
This went very well. How can we do this again? This was challenging for us. How can we do things better next time?
As part of this step, team members propose improvement actions. Learning points are shared by the team members.
So what can the team learn from this experience?
Key actions.
Team members agree on solutions and take responsibility to carry them out and follow them up. What are we going to do? Who is going to do it? How will we all know that it's been done? Talk enables teams to make small changes that matter. Small changes can make a big difference.
Talk allows a simple framework which guides a learning dialogue. It should encourage all team members to speak up and everyone's opinion is valid. It can be really difficult to introduce new things within cardiac surgery, and it might be a good idea to start slowly. Examples of when it might be useful include new clinical procedures, such as minimally invasive procedures, good outcomes in difficult clinical situations, or near misses and challenging cases. It's always important to focus on finding solutions. I'm sure whilst you're listening, you can think of an example of a situation or a case that would have been good to debrief. Debriefing may be particularly useful when you've got new team members. Although most of the team work together regularly, there will be a continuous rotation of junior anaesthetists. Examples of situations which you may want to debrief include big things such as drug errors or circuit component changes, but mostly it will be marginal gains and small things to make the day go better. Such things include how to ensure if the low operating table is available for certain patients, where to do the morning briefing so as not to panic the patient, or it might be simply, how can we get hold of the perfusionist quickly, and writing the office number on the whiteboard by the phone could solve that problem. We're all responsible for providing good quality patient care. The small things and changes and small gains that we do will help us work together better as a team. You may be debriefing without knowing it and not making it formal. It might be a 1-minute conversation at the end of the case where the perfusionist says, "I'm glad we had the lines at the table before we opened the chest. Should we do this for more cases?" This is something that we actually do as routine in Cardiff. The lines are handed up and the cardioplegia and the suckers are checked before the chest is opened. This means that all of those safety checks aren't missed or done in a hurry or in an urgent situation. We have to acknowledge that we may have new challenges due to the pandemic, particularly communication. Wearing PPE, different visors, and particularly the respirators, can really impair what you can actually hear. You're also going to lose certain body language cues. The whole team could be tired, dealing with lots of other life stress and things that are going on. And you may need to work in an unfamiliar environment. Has the whole team been called in to do an emergency and had to use a different theatre? Did everything work okay? Did you need to use alternative gas pendants, and could you access everything that you needed? If you were to be called in again, would you do anything any different or choose a different theatre? A debrief may be an opportunity to mention useful training resources. There's a huge amount of free webinars available now, and it might be worth suggesting some to different specialities so that we can start breaking out of working in an early learning from our own silos. The talk framework can be used for whole team debriefs, but it can also be highly valuable when it's one-to-one debriefing following a case or just a teaching experience. This particular app takes you through certain aspects of cardiac surgery, and it can be really useful for new starters or those that aren't currently able to be in theatre at the moment. You can take them through what happens, and you can also use the talk framework to help you guide this debrief. Thank you very much for giving me the opportunity to talk to you on this, and I'm looking forward to answering questions later. If you want any more information, the website is the best port of call, but you can also email us directly here. Thank you. Thank you very much for joining and watching that session. And I'd be really grateful if you could score on the poll that should be active just below. Thank you. I'd like to introduce our next speaker, who most of you will have heard of, Letty Mitchell. So Letty is a movement artist, yoga and mindfulness teacher. Her work focuses on mindfulness, mental health awareness, yoga, anatomy, chi, creativity, the links to neuroscience, as well as the concept of reality. She's worked in the medical, wellness, fashion and creative industries, and I'm sure we can all agree how critically important mindfulness and mental health is when we're working in such a stressful environment. Letty's worked with lots of companies, including Adidas and Nike and Soho House, but she's also had much involvement in leading sessions on mindfulness and resilience with the Society of Cardiothoracic Surgery as part of the surgical training portfolio. She's spoken at SCTS conferences and has been part of the faculty for webinars which are supporting allied health professionals and nursing staff recently. So I'm going to pass you on to Letty now. Thanks.
Hello, my name is Letty Mitchell, and it's a great pleasure to have been invited to speak to you today about equality and diversity. I am a yoga, a mindfulness, and a meditation teacher. And the beautiful truth is that these practices share very similar scientific advantages in improving our well-being. And importantly, in reference to equality and diversity, they help us really understand our connectiveness as human beings. So I'll be looking at equality and diversity from this perspective, drawing a lot from my own personal experiences, as well as my professional experiences, learning and teaching conscious awareness, and how this can lead to equality. Some of the questions that I've looked at in previous research and we'll talk about today is, where do our prejudices come from? And how can we start to become more aware of ourselves? How invested are we in understanding our own subconscious minds to see where most of our behaviors are coming from? And importantly, I believe, the question, do we give ourselves enough attention? Mindfulness meditation is an example of a practice that gives you the space and the stillness you need to answer some of these questions, to simply be rather than do. And it's a chance to get embodied. And why is embodiment important? Embodiment is presence. It is our existence beyond the analytical mind, the mind that is full of bias and survival mechanics to make us feel safe. We know that about 99% of us have, to some degree, some kind of unconscious biases towards people who are different from us. Research suggests that unconscious bias occurs automatically as the brain makes quick judgment based on past experiences and backgrounds. And these unconscious prejudices make sense. Yeah, they were formed back in the cavemen days when you would approach somebody, they look different to you, and you perceive that as some kind of threat to your survival. But we're in 2021, we're in 2021, and we're surrounded by people who look and talk different than us all the time. But the brain, our brains, to some level, are still wired to equate outsiders as a threat to our survival. And Paloma Medina mentioned something in one of her TED Talks about this subject matter, and she mentioned it means that even if our mouths were saying, I want diversity in my workplace, your limbic brain is saying, but please not too diverse. And just like animals, we are innately able and we understand how to spot injustice. Experts theorize that we seem to be wired to scan for equality in particular, because, as I mentioned, it is linked to the cavemen days. And the brain categorizes equality as one of our core needs. And when our core needs are threatened, our brains, as well as our bodies, are wired to go into a stress state. And this will influence our thoughts, our actions, our emotions, and our behaviors. Importantly to say, having an unconscious bias does not make you a bad person whatsoever. It means you are human. But we need to acknowledge the effects these biases have on other people. And the fact is, as a result of unconscious bias, certain people benefit, certain people do not benefit. Conscious bias, explicit, deliberate acts of racism still very much exist in the workplace. But more importantly, due to our unconscious, implicit biases, recurring microaggressions are being allowed to play out without consequence or accountability. And here are just a few examples of what verbal or behavioral microaggressions can look like or sound like. Where do you come from? I personally get asked that question a lot. And, consciously or unconsciously, by asking that question, your brain has already determined that that person is not meant to be there. I think she writes like that because English is not her first language. How can I be racist? I have a friend who has a black dad and a white mum. You look exotic. And some of the behavioral kind of traits, being left out of work conversations, colleagues talking about you behind their back within the workplace, deliberate preventing of career development, senior colleagues blaming you for their mistakes, and being judged based on personal choices. And I just want to really clarify and say that although some of these things may be very extreme, these are all microaggressions and behavior that I've personally received. And this is just a handful. So the discerning fact is that many people of color have to experience a tainting of their name and their professionalism due to someone's assumption of you. And more commonly than not, if the victim addresses the situation, they are seen as troublemakers. And if they are a person of color, some of the stereotypical names that we're called are aggressive, intimidating, and I've also been told I am terrifying by speaking out. Very, very common words. And I've been in situations where the support systems are not put in place. But speaking truth to power takes strength and it takes courage. Especially when your truths are met without any empathy, compassion, or respect. But I still want to inspire those who are really invested in creating change to speak out, regardless of whether you think that you will be seen and heard, to be brave and to stand your ground, but to always prioritize self-care. And the reason why I want to mention this is because reoccurring microaggressions within the workplace that is already systemically racist creates hostile work environments for people of color to work in. And as a result, this will significantly impact your health. And just for a little bit more clarity on this, hostile environments lead to higher stress levels. Chronic stress leads to inflammation. Inflammation in the body is directly linked to heart disease, cancers, and just a general lower life expectancy. And research has proven that people who experience recurring racism show chronic inflammation in their bodies. So I really, really want to highlight that equality is not just politics or a cyclical trend. It's not about putting our hands up to join a diversity forum for a month, or posting a black square on social media, or for a company to, declare an allyship that have no legs to stand on. Equality is critical to our health. And if we understand, if we truly understand, if we open our eyes and our ears up to the information that is available to us, so if we understand this, the racism, the systemic racism in institutions like the police force, then we need to accept the same within the medical industry and make radical time-bound changes, because the time is now. And in terms of evidence, it is available to us, and there is a clear bias towards white people within the healthcare industry. And just to name a few facts here. Black mothers are 5 times more likely to die in pregnancy than white mothers. Black people have a lower life expectancy because more of them live in areas of deprivation compared to the general population. Black people are more than 3 times more likely to be detained under the Mental Health Act. And I'd like to point here, one of the reasons that has been researched is the gap, the cultural gap between the professional diagnosing this person as mentally ill. It's just a cultural difference. And in 2018, Black people had the highest unemployment rate of any ethnicity at 9%, more than twice the white population at 4%. And lastly, in terms of earnings, in London in 2018, ethnic minorities earned 21.7% less than the rest of the population. Accountability. We need to start taking accountability and do the self-work so that we can start understanding our own conscious and, importantly, our own subconscious programmings to know whether we are being part of the solution or whether we are being part of the problem. Around 90% of our thoughts are governed by our subconscious minds, stemming from past experiences and old, outdated behaviors. Not just our own experiences, but the experiences of our parents, our grandparents, and every ancestor that preceded them. And if we do not stop to observe these hardwired, outdated beliefs and programmings that are causing us to live in the shadow of our past, then cycles will only continue and nothing will change. And racism will continue, and only those who are profiting from a lack of evolution will benefit. And I'm fully aware that accountability is uncomfortable. I've personally spent years and years of shadow work looking at myself, looking at my own behaviors, and it forces you to stand in front of the table of your own life, your own actions, and take responsibility for your choices. Accountability is not about blame, neither to oneself or another, and neither is it about shame. Accountability is taking responsibility for your own personal growth to fuel the collective mission for greater equality and diversity in the workplace. And I really want to now really speak to the companies and seniors and head of departments that hiring people from minority backgrounds just to tick status quo boxes is the easy first step. It's very easy to do that, but it does not say anything about how these colleagues, how these staff members are being treated. Are they being treated the same as their white colleagues? Are they being given the same opportunities for career development? Look at your staff, look at your team. How many people of color do you have working alongside you? I would also add, how many people of color are you friends with? And when was the last time you've ever even stopped to consider these questions? In response to the Black Lives Matter movement, you know, growing number of people are speaking out, especially in the medical industry, and they're sharing and they're speaking their truth. And it's so beautiful to see supportive communities are growing and gaining momentum, because silence only enables discrimination to continue. Open, transparent conversations are key. And privilege is invisible to those who have it, and is often the reason why these subject matters and these talks are often rejected. But I really do urge everybody to speak up, to be brave, and to remember the interconnectedness of us all. And I'll leave you just with a few words that I've always based a kind of my teaching, my lessons and my life on, that reacting to this life with more awareness of self will support the dismantling of racism. Because if we don't change, nothing changes. Thank you very much.
Thank you very much, Letty. Lovely to see you after quite a while. So I'm just inviting everyone back now, please, to talk. Unfortunately, Rakesh can't join us, but Jody and Letty, would you like to open your camera to me? Hello. And welcome to everybody that's joined us, actually. Just looking down the list, there's a number of people from across the country, so thank you very much. I'll just ask you to poll for that last session now. And while we're doing that, I think probably it'd be worth just, there's a few questions in the chat. Please go ahead and post any more that you would like to. Really looking at this session, it sort of crossed quite a number of boundaries, really. And I would say that the key messages that we'll probably highlight in the conversations that we're about to have would be around the fact that, you know, the first presentation on mobility and nutrition really underpins IRAS, and IRAS movement that's happened over recent years has definitely allowed us to pay greater respect to the extended surgical team and working with all our colleagues together, and the benefit that that brings to our patients. And the whole notion of sort of, I suppose, blurring what was traditional professional boundaries in terms of joint skill sets now and how we can all work together. And then looking at the presentation around the careers and allied health professionals and advanced practice, we've certainly got sort of a development with workforce change there and lots of opportunities that present to us. And then if we look at Jody's presentation in terms of debriefing and that opportunity for a constructive look at lessons learned, I think we have a huge, I suppose, opportunity there to look at using that to underpin challenging our lack of human and financial resources where needs be, or just enhancing what we feel we've got. And certainly putting that within the context of a governance structure as well. And then last but not least, definitely coming to Letty, you know, what sort of a colleague are we? What sort of a leader are we? And how are we now? And where would we like to be in the future? I think that really underpins what the message was that Letty was trying to come across. So now the polling is closed. I'm just going to field the first couple of questions that we've had. So Hannah from Bristol, thank you very much. You've put a question around the difference of banding and remuneration, I presume, from the ACP and the ANP. In terms of the question itself, I'm a little bit, I just need to pull a couple of bits out from it really. Your question says that the ANPs that you currently work with are banded at band 7 and are loath to repeat other courses that they've already undertaken to become an ACP. So my interpretation of ACP is the words mean advanced clinical practitioner. And in essence, that is advanced nurse practitioner as it used to stand, but the title has changed so that we can encompass all the skill sets of our allied health professionals. So our allied health professionals now don't just come from a nursing background, they come from a variety of backgrounds, as the talk said. And so the trajectory across the career development shouldn't be any different, really. And I think if you're in a position where you're being sort of, you know, recognized at a different level to colleagues, it's around working out what's the skill set. Are you doing the same position they are you sitting on the same level as they are? And in which case, you know, there's lots of ways around that I'm happy to share with you on looking at transferring and how you align with what's been going on and how you amass the evidence for that. So I'm not sure if that answers that question, and I'm going to ask you to come back to me in the chat if it's not covered what you meant, and it hasn't included ACCPs, when there often is a bit of a difference as well. But hopefully the work from Health Education England and all the frameworks are now bringing that together. So I'm just going to bring us on to our second question now, if I might. And while we answer that, if you think further, Hannah, then please come back to us. But the second question is yourself, Jody. And I think it was also from Hannah, and it was around the fact of, you said debriefing can be at, you know, straight away or sometime afterwards. We call upon your expertise to tell us how long is too long, in essence. I think that question asked, you know, when does it lose meaning if you leave it too long?
I think that every situation is different. There is a benefit to doing it straight away because you'll have all members of the team there, so everyone can sort of interact. But I actually don't think there is a circumstance when it can be too long. So, for example, if we have a case where it's a Jehovah's Witness patient and they leave theatre with a really good haemoglobin, for example, that doesn't happen by accident. That's because all members of the team have proactively worked together to make sure that happens. And I think we forget often that there might be new members, new nurses, new anaesthetists that don't really know what everyone's role is and what everyone is doing. And so if there is a period of time where you're sort of quiet, you could all just, or even just a few members could sit down together and say, okay, that went really well. What did we all do together to get this good outcome so that we can make sure we do that for future patients? Similar for if it's been a challenging case, often in perfusion, if we've had a difficult case one week, the next week we might say to the rest of the team, or let's sit down together and talk about that case so that if it happens to you, you know how to manage it, and both positive and sort of negative things. And I think there's always a benefit really for doing a debrief.
Thank you. And actually, I noticed you talked about sort of a no blame culture in that, and obviously looking at human factors. Letty, can I ask for your opinion on sort of, you know, the best way forward from your perspective, taking account of all the sort of the messages that you've tried to give us today?
In terms of when to share?
When you're, so debriefing is a time where we often have to deal with things that haven't gone as well as they might do. I don't think we're as good at dealing with them when we've done things well, which are clearly very important as well. But if we're dealing with things that haven't gone as well, how do you make sure that we, you know, the conscious bias in the way we hold those conversations and how we involve everybody? What are the key things that you think that we should really take home from today?
I think one of the main things for me in terms of this work is, and something I've learned from my own experiences, is being kind of, even if you feel the resistance to it, speaking about it when it happens. I think that's one of the main things, or as attuned to the experience, speak about it. Because then you'll have weeks or months or years manifesting a story, some seed or something that's happened, creating all of these false narratives in your head. And then when you address it, actually the seed that what's happened is grown into a massive oak tree, and it's massive. So one of the first thing would just be the time bound, the time that you explore it. I think in terms of this work is really taking yourself time for yourself. So there's a little bit of an echo there. Just allowing yourself to, instead of react, to take a pause, to breathe, and actually when you come back into the experience, you're responding. So you have more clarity and more space, and you can respond rather than reacting it. So that would be my suggestions.
I think very wise words. And actually, as you were talking there, it made me think of one of my, teams I work with that will know my favourite comments are, what have you seen in your career that you thought, oh, I really want to be like you when I'm a grown up, or I really want those aspects of you when I'm a grown up. But then the other side of the coin is when you've seen behaviour and you think, gosh, I really don't want to be like you when I'm a grown up. And I think actually, that the whole sort of culture and the move of the society now to embrace much better working for everybody is one that's quite inspiring. And I think that the notion of not being able to speak out as it affects your career prospects is huge. I don't know if either of you got any thoughts around that at all.
Yeah, I mean, for me, it's the case. If you speak out in certain environments, you will be met with resistance. If you speak out amongst a team that is not there to move or to change or to see where can I make things happen and make things better, you will be met with resistance. But I think then it becomes again accountability and self-awareness to be like, if this is important to me, and if I know that this is my truth, and I'm responding compassionately, then I'm going to speak regardless of whether my team initially reacts with resistance. Because what I hope is that the more that we think about it, the more transparent things will become, and we'll realise we'll get into this culture that speaking about certain things is not negative. Being able to say something, I feel you did this, it made me feel like this. That's not a negative thing. That's not a blame game. That's not bullying. That's just exposing the fact that your actions created this in me. And can we make something or communicate together as a team so that we understand each other's perspective on stuff? I think that's what it is for me as well. I just really encourage, and I said it in my presentation, often when you speak, we're perceived like I'm often really perceived as being super confident and really confident, and I am, but I've done about 10 years of self-work to get to this place. So this isn't something that will happen overnight if you're slightly shy. But once you get used to interacting, speaking a little bit more truthfully, then it'll become a little bit more easier. So that'd be my advice.
Yes, thank you. I mean, I think we're just coming to the end of the session. So I think probably in summary, it's more around how we express ourselves. And that's a learning curve, isn't it? And it doesn't come naturally to everybody, or, all of us, we have to learn. And certainly some of the things that I've learned along the way are, using a conversation to say, oh, this is what you just said to me. Is that what you meant? Or did you mean it to sound like that? And I think some of our way of, constructive challenging is to work out, how we want to say something, so that it's actually, if it was being said the other way round, how would we want to hear it, bearing in mind that people are sometimes not happy to listen. So I would really like to thank, obviously, Rakesh, who's not with us, but Jody, was there anything further that you wanted to add, or just to say thank you very much to everybody?
No, I'm just really grateful to be part of this session today, and I think the things that you've covered are so important. I think that when you first start working in cardiac surgery environments, you're very focused on the technical skill and being able to do the job correctly, and you actually don't necessarily consider the relationships and the all the other sort of non-technical things as much. And I think it's starting to bring those things into the forefront, recognizing that we have the unconscious biases that we do, recognizing what we all say and how we speak to each other. And ultimately, we spend probably more time with our work family than we do our home family, and we'll be with sort of a huge amount of time of our lives in our professions. So we do need to work on all of these things to be better for our teams and our patients.
Well, thank you very much. That was really nice to work with you on this. I look forward to working with you in the past, in the present as well. I think you bring a lot of things to the table that are important. Letty, it's delightful to see you again. Haven't worked with you for a while, so thank you both for your contribution. Thank you very much to the audience. Your next session is the professional opportunities and equality in the SDTS for nurses and allied health professionals. It starts at 3:30, so if you take a quick comfort break and then rejoin us. And thank you very much for the afternoon, and look forward to the next few days. So, all right, good night, or let's see you shortly. Bye.
Bye.